Good afternoon, everyone. Thank you for joining us today to learn more about our new 5-year strategy, and in particular, this focus area of care closer to home and community with safe transitions. Just a reminder that all of these sessions are being offered with interpretation, and so you can go to the menu bar at the bottom and choose the language that you would like on the interpretation button. So, to introduce myself, my name is Carol Fancott. I'm the Director of Patient Engagement and Partnerships here at Healthcare Excellence Canada. And I am joining you today from Toronto, which is on Treaty 13, the traditional lands of the Mississaugas of the Credit, Haudenosaunee, Anishinaabeg, and Wendat people. And I recognize a privilege that I hold to be able to live, work, and play on these lands. And I am joined today by Aggie Black, who is the Director of Health Services, Clinical Research, and Knowledge Translation at Providence Health in Vancouver. And Aggie is a registered nurse and has been on the team lead on one of the teams of our Bridge to Home initiative at Providence. And I'm also joined by Christine Walsworth, a patient and family partner who has worked with Aggie and team at Providence to improve and to implement patient-oriented care transitions. And thankfully, Christine has been connected with us here at HEC through strategy development, and most recently as a reviewer on the implementation science teams related to our Long-Term Care Plus program. And so in the next 20 minutes or so, and it looks like we have a little bit more wiggle room if we need, I'm just going to share very briefly with you some of the ideas and work that we have in this area of care closer to home and community with safe transitions. You're also going to hear from Aggie and Christine, who will speak about their work together with us. And then importantly, we really want to open up the dialogue with you through the chat to understand from you and to learn from you what would meaningful improvement look like in care closer to home and community. And so we know this idea of care closer to home and community is not new. And interestingly, what we've seen through the pandemic is care in the home in new ways, through many more virtual care offerings for all types of care. The rapid adoption of virtual care has occurred at a speed that I don't think anyone could have anticipated. And we're still learning when virtual care has been most effective, when it is not, and how really to deliver virtual care in ways that support equitable, culturally safe, and patient-oriented care. And so to this end, HEC has partnered with Canada Health Infoway to advance virtual care change management. And this is part of Infoway's initiatives to develop and expand virtual care solutions across Canada, and also part of HEC's efforts to shift care closer to home. The Clinician Change Management Initiative focuses on providers and other members of the care team, which includes patients and their essential care partners, to improve virtual primary care experiences and outcomes for patients in community settings, with the intention that this work will be scaled to other clinical areas. So this new program, which was just launched recently, is going to be working with 20 community-based primary care practices across Canada to implement and to evaluate equitable, safe virtual care that really meets the needs of patients, of communities, to enable and to improve experiences and outcomes for patients and for providers alike. We also know that providing care closer to home and community requires better integration of health and social services to enable safe transitions. And one of HEC legacy organizations had implemented a collaborative previously called the Bridge to Home Collaborative. And in this collaborative, we were able to support 16 teams across Canada. And Aggie and Christine were part of that collaborative. And in this collaborative, implementing evidence-informed, patient-oriented care transition innovations. And so now we are working actually with one of the Quebec teams to actually do a pilot spread in Quebec, and where we are supporting their work with learning webinars and other lessons learned. In this original collaborative, teams were encouraged to form networks. That is bringing together healthcare institutions, but also together with home care, with primary care, with community care organizations. really understanding that it's these relationships and connections that are needed that help these organizations ensure safe transitions from hospital to home. And all of this is done, of course, with patients and caregiver partners who have worked as part of the improvement teams to ensure that improvements truly are grounded in the lived experiences of those receiving care and in the communities. So I'm going to hand it over now to Christine and Aggie, who will speak briefly to their work on Bridge to Home as an example of what meaningful improvement can look like and has looked like for them at Providence Health. So over to you, Aggie.
Great. Thanks so much, Carol. Whoops. Do you guys hear me? Should I mute? And no, that's better. Is it gone? Okay. My voice sounded a little scary there. So I'm joining you from the traditional territory of the Kikite Nation near Vancouver, BC. And I'm really happy to have a chance to tell you about our experience working with what was then called Canadian Foundation for Healthcare Improvement on the Bridge to Home Collaborative. The aim of the Bridge to Home, as Carol said, was to improve the transition of patients from hospital to either home or community through the use of a process called PODS, Patient-Oriented Discharge Process. And that included 4 components. There was a PODS discharge form. We engaged caregivers when we did discharge teaching. We asked the nurses and social workers to use teach-back principles when they did their discharge teaching. And we had follow-up contact with patients after discharge. We knew at Providence we had some room for improvement in this area. We weren't doing as well as we wanted to at preparing patients for that transition or their caregivers. And we also knew that CFHI had a great track record of working with teams, supporting them to spread innovative, proven practices. So the support we received was in many, many forms. We had workshop training, mentoring and coaching, basically almost any time we needed it. We could reach out to Carol and her team. We were introduced to other teams so we could learn from their successes and try to avoid some of the pitfalls that some of the other teams might have made. And we also got funding, which was super helpful. We also had countless supportive emails, phone calls, and were directed to resources whenever we needed it. So our PODS project in 2 medicine units at St. Paul's had some what we thought were pretty remarkable outcomes. 60% of the patients on the implementation units received PODS. 88% of patients who received PODS said it was helpful. There was a large increase in the number of patients who said they felt prepared at the time of discharge. There was a large increase in healthcare provider confidence about their patients' preparedness for discharge. There was an increase in the number of patients who rated their overall hospital experience a 9 or 10 out of 10. And there was even a small decrease in our 30-day readmission rate. So all of this is, if you want details on any of this, will be published in November in the Patient Experience Journal. PODS has continued on those units where we implemented it, and it has spread very successfully to 1 additional unit. It would have spread a lot further, but healthcare is a dynamic environment. And at the same time that we were finishing our implementation of PODS, our entire organization transitioned, I guess I would say, to electronic health records. And to get a new form into the electronic health record Cerner has been challenging, or been a longer term process than we thought. But again, Health Excellence Canada has been really helpful by introducing us to a team in Ontario that has done this exact thing, putting their PODS form in their Cerner system. And that team is going to share their implementation strategy and even their coding with us. So as you can see, we're still super excited about the possibilities of PODS, the ways that it has helped our patients and their caregivers, and the ways that it will continue to. And we hope to continue to spread it through our organization. And I'm going to hand it over to Christine to talk about the ways that she was engaged in this project, which was incredibly helpful to the whole team.
Thank you, Aggie. Hi. To give you a short bio, I'm a patient and family partner, or PFP, and I volunteered within the healthcare system for almost 10 years. I was the care partner of 21 years for my late husband, Bill, who had both Alzheimer's and Lewy bodies dementia, as well as multiple comorbidities and numerous serious operations. Over the years, I was not only his care partner, but also his advocate throughout his journey. PODS is a project that's close to my heart because, as I mentioned, Bill had numerous hospital stays, and I have to say that we did not experience one good transition from hospital to home. This was especially difficult as his dementia progressed and he needed more care at home, which unfortunately was not always taken into consideration within the discharge process that was in place at that time. So for us, the hospital discharge system was broken and needed fixing. Working on pods was a way for me to help in a change in a positive way. And as one of the PFPs on this project, one of the things I most valued was being part of the pods team from the beginning. This meant that I provided input into writing the CFHI proposal. I was also involved in all team meetings. I had input into the policies and procedures and also the design of the pods materials, as well as talking with staff on the 2 units about the importance to patient families of pods. In other words, as a PFP on pods, it was a fully collaborative and empowering initiative to be involved in. CFHI, or HEC as it's now called, supported our team by providing funding for the project and provided help through workshops, mentoring, and through their webinars that, for example, offered team building strategies and how to brand pods that would help spread the collaborative. These sessions were held via Zoom and offered the chance to ask questions of HEC or of other teams that were also taking part in the collaborative. HEC also offered practical help with document templates, for example, the PODS forms, so that we were not starting completely from scratch. I also knew that I could contact HEC with any questions that I might have. I am extremely proud to be part of the PODS project, as this is a systematic way for patients, caregivers, and staff to ensure that patient discharges are more successful. And as you can tell from our presentations, that PODS is a collaboration with healthcare providers, as well as patient and family partners, and with HEC. And as such, we all became allies that together found a better discharge process that's a big step in the right direction towards patient-centered care.
Thank you, Christine and Aggie. Sorry about that sticky mute button there. Really inspiring to hear about your work and the difference that it has made to those receiving care and caregivers. So now we want to turn it over to you, all of those of you in our audience today, of really trying to understand what would meaningful improvement in this area of care closer to home and community with safe transitions look like. And we invite you to add your comments in the chat. I was just noticing, Laura, you had asked about the PODS, which is the patient-oriented discharge summary. And we, as I had mentioned here in the chat, we worked very closely with the innovators from Open Lab at the University Health Network. And I think what drew us to this innovation was that it was co-created, co-designed together with patients and caregivers from the outset, and that they had tested this innovation in a spread initiative in Ontario. And so we knew it was evidence informed, but what was really important to us is that it was patient oriented. So while we are waiting for folks to put in, what does meaningful engagement and meaningful improvement look like from their perspectives for care closer to home and community, maybe I'm going to turn to you, Christine and Aggie. One thing that the pandemic has certainly revealed is, issues of health equity and inequities that continue to exist. And so when we talk about equitable care for all, what does this mean to you when you think about patient-oriented care transitions?
For me, it actually means putting humanity back into the healthcare setting and to actually see beyond the diagnosis of the disease, to truly see and connect with the patient as a person. With this in mind, I think that healthcare providers need to ask and actively listen to what the patient needs in order for them to have a successful care transition. So it could mean anything like patients asking to have their medications ready before they actually leave the hospital. Because I know with my husband, everything was blister packed, because he was on so many medications. So to have that actually ready before he left would have been a great help. But also, PODS actually also piloted a follow-up phone calls, which I really strongly think that whenever somebody embarks on this process, they should continue doing those, because recently discharged patients were overwhelmingly positive in their feedback to the person that was phoning them. This also speaks to patient-oriented care transitions, as it reassures people that PHC did actually care for them and did take their health seriously. And it was especially good for them to actually hear a live person rather than a recording. So I would seriously ask if any teams actually take PODS on to make sure that you actually figure this into your plan, because it was a great asset.
So that human touch, human connection, Christine, really makes a difference.
It does. It makes a huge difference.
Aggie, do you want to jump into this around thinking about equitable care from the perspective of someone that's actually implementing innovation into practice?
Yeah, I would say the more I study equity in healthcare, the more it's clear to me that people like me who speak English and have no problem communicating and advocating for myself, that PODS form was really useful. But who it's absolutely critical for is patients who maybe don't speak English, aren't comfortably housed, are facing other challenges. And for those people, it really becomes sort of a roadmap where the social worker has communicated with the care manager at their shelter. And the PODS form is going to be also sent to the case manager at the shelter so that she or he has a little roadmap. So that person who maybe doesn't have a caregiver there at the time of discharge has a piece of paper that says your walker is going to be arriving tomorrow, donated by Red Cross. So I think when I think about equity in healthcare, I think all of us need a PODS form because it's a great roadmap. For some people who are facing even more barriers, accessing care and having a smooth transition, it's even more important. So for me, it's just been, I would have loved, like Christine said, I would have loved to have had a PODS form when my father-in-law was discharged. And, the discharges that I've personally been a part of, a PODS form would have been a great roadmap. But I think it's particularly important for some of the populations we work with who face multiple barriers and challenges.
Thanks, Aggie. And what's, sort of to build on what you're saying, I think one of the beauties of the PODS form itself and where we have seen it adapted to a number of different patient populations, a number of different communities, but it forms the base to begin with, but can be adapted and has been adapted not only through our collaborative and many of the teams that worked with a myriad of different populations, but also what we've seen in the original spread in Ontario of working with various populations. I'm going to go to the chat now and thanking Tanya for her comments. And if I've read it correctly, Tanya, really being able to use something like care standards as a lever for change as well in helping to shift resources more into the community. And I think the example that you're using here is acquired brain injury, for example. So really ensuring that the resources that people need are put in the places that are required, particularly when they're transitioning from institutionalized care or rehab, outpatient rehab, into the community and at home. And so how might these standards be useful in ensuring that those resources then are put in place as part of best practices? So thanks for that. I see Lori has also asked a question about work being done, access to pregnancy and birthing services in small communities. So that's a really interesting question, Lori. What often happens in many of our collaboratives is that we are focused on particular innovations or particular areas. So the example that I used about virtual care and clinician change management that's happening in primary care. Some of the primary care teams that are working with us may very well be those in rural or remote areas that would then have implications on the populations that you're suggesting, like pregnancy and birthing services. So that some of that work might be happening through there. It depends on the teams that apply, where teams are demonstrating readiness and are interested in working with us, and then become part of the initiatives or the collaboratives. Can we see the PODS form? Yes, I will pop in the link. UHN, so University Health Network, who is the innovator, has an entire website page with a number of their resources, etc., linked to that. So I'll be sure to pop that into the chat. Aggie and Christine, I welcome you to comment on anything that you're seeing in the chat as well. And I am seeing Robin, thank you for joining us today. And I am so sorry to hear that what happened to you, having received your surgery in the Toronto area, but then returning to your home in Nova Scotia, and that you were not able to access home care, which is interesting. So this is an interesting conundrum, understanding that we have 13 health systems across the country, and so what does this mean in terms of integrated care and to be able to receive care across borders? And so can HEC recommend universal practices across Canada? So thank you for raising that. And I think what I would let you know, there are many conversations that HEC is involved in, and certainly knowing that there are regular conversations that happen across provincial and territorial leaders. So that can certainly be something that does get raised. But thank you for sharing your experience, Robin. Christine and Aggie, anything that you would like to join in? Oh, you were refused home care follow-up in Toronto. My apologies. So that would be a different situation, but I do feel like it is a similar issue that can be raised at the tables where we are involved, and certainly with provincial and territorial leaders, I think, to try to break down some of those barriers. Thank you for clarifying that, Robin. Christine and Aggie, I'm turning to you if there's anything that you're seeing in the chat that you want to add to. And we do encourage you, I was just going to say to the audience, please continue to add your comments and thoughts on meaningful improvement for home and community care. Definitely being able to access home care would be one of those. So thank you for pointing that out, Robin. Christine and Aggie, anything that you would like to add?
I would like to add that the POTS form, although it came, you gave us a template, we did extensively change it. And it was a collaboration between both myself and another patient partner and the healthcare staff. So you can change the forms. You don't have to, so long as you have the basics, you can use that form to suit your needs. And you can use language that actually makes sense from a patient partner or a patient point of view, as well as healthcare staff, because everybody has to use it. You know, it's useful if you have everybody at the table having their input into what it should look like and what it should say.
Yeah, I would just add to that we took the form around before we did our implementation and showed it to some patients on the medicine unit and said, if you got a form like this with a conversation, you know, explaining it, would that be useful? And except for one person who said, I don't ever want more paperwork. Everyone else said, yes, that looks really good. And one of the things that Christine and our other patient partner pointed out was that the icons on the PODS form, you'll see there's a little icon for symptoms you might be feeling. There's another icon for these are my medications. I can't remember what the other icons are, but the patient partners said these are really useful because even if you had limited English, you would know that this section of the PODS form is talking about medications. And the forms people in the healthcare system were like, oh, no, we can't have icons on there. Doesn't look like a hospital form. And Christine and our other patient partner said, exactly, it doesn't look like your regular form. This is for us, not for you. And it was such a aha moment for me. Like, so much of healthcare is designed for us as healthcare providers. It works in our language. The forms do what we want them to do, and we rarely stop and say to the patient and their caregivers, how's this form working for you? How's this process working for you? And PODS really let us step back and say, what about this form do we love, including asking patient partners, what do they like and what do they want to keep? And then also asking nurses and social workers and pharmacists, what do you think about this form? And all of them, when we said the patient partners want the icons to stay, all of them said, yeah, of course, I could see why they would. But unless we'd had that extent of collaboration, we wouldn't have known, and the icons might have gone out and the form wouldn't have been as useful. So that was another, and that was really CFHI saying, we don't want your patient engagement to be a checkbox. We really want you to be thoughtful. We want this to be engagement, as Christine said from the beginning when we wrote the application to participate in the collaborative. Christine and Kimberly were part of that, and they said, you make sure we're doing this, make sure we're saying that, and yes, we would like to be involved in this, and one of us would like to attend the workshop. And it was it really, really made a difference. And while I have the microphone, I'll just say that one of the most meaningful parts was having Christine, which I think is not every patient partner would be comfortable doing this, but she went to the unit and spoke directly to groups of nurses to say, this is what a good discharge process would look like for me. And here's what it feels like as the caregiver, particularly for someone with dementia, when I didn't understand, or where you didn't talk to me, or where I was given no information at the time of discharge. And I felt like that nothing moves healthcare workers more than a patient saying, this is what would be useful to us, and this is what was not. So that was really meaningful to have her come right to the units. Now, we couldn't do that during COVID, but I think, people could find creative ways to bring people in by Zoom now. And it really meant a lot to the staff.
Well, thank you, Christine and Aggie. And I feel that the experiences that you've shared really highlight what partnership looks like in action. And I think to your comments, Christine, of it needs to work for everyone, and for everyone to be able to understand the varying perspectives that need to be brought to bear, and what it looks like from a patient caregiver perspective of what's going to work, and also understanding from the staff perspective of their workflow and their workload of what's also going to work for them. And it's when it comes together, we begin to see change and improvement, as you've described. So thank you very much for that. And thank you to all. I'm aware we are in our final minute as we close out this session, but just want to thank Aggie and Christine again. Thank all of you in the audience for coming into this session to learn the ways that we're thinking about care closer to home and community with safe transitions. And on this slide, you're going to see some of the ways that you can stay engaged with us here at HEC through our website, where you'll see strategy and current opportunities, joining conversations with us, and participating in Canadian Patient Safety Week, which is happening at the end of this month. And many of you will be aware that the theme for this year is Who Knows Essential Care Partners Do, which really highlights the essential role that caregivers play in the care of their loved ones, which we saw, particularly in the early days of the pandemic, the detrimental impacts when they're absent, as a result of their absence, on patients and on residents, but as well caregivers and providers. So we look forward to working with partners like all of you across the country to realize the shared purpose of improving the safety and quality of care for all. So thank you very much again, and this concludes today's event. Have a good day, everyone.
Thanks, Carol. Bye.
Bye-bye, everyone.